We're back at HudsonAlpha after a month of staying at home, which means the quality of these videos gets much, much better. Let's explore what some of the science has told us over the last month about symptoms, disease severity, and testing. Welcome to Shareable Science. Science you can share. So there's been a lot of new science that has come out in the last several weeks related to COVID-19 and the SARS-CoV-2 virus that causes COVID-19. Let's hit the high points. First, symptoms. We've spoken a lot about this common set of symptoms: fever, cough, and shortness of breath. A couple of weeks ago, the Centers for Disease Control added a whole new set of symptoms: chills, shaking with chills, muscle pain, headache, sore throat, sudden loss of smell or taste. So these are an additional set of things that potentially might alert you, taken together, not any one of them on their own, that potentially you need to seek medical attention related to COVID-19. And also there's something called COVID toes. So this is when multiple toes on your feet turn red and then maybe over time purple or even dark blue, like bruising. This is being seen in an increasing number of cases. It hasn't made its way to the official list of symptoms, but it is indicative of what we think is happening as we understand how COVID-19 affects the body, which actually leads us to the second piece. We've spent much of our conversation focusing on the impact of the virus on the lungs, specifically the inflammation, the narrowing of the airwaves, and pneumonia. We now understand that the virus actually attacks multiple other parts of the body as well, especially in terms of inflammation and in terms of small and large blood clots. So issues with the brain, the heart, liver, kidney, and the intestines. We're seeing an increase in the number of individuals who have strokes or who have kidney damage from clots in the kidneys or in other organs. So we're beginning to understand that while we focused on the lungs as ground zero, the virus really is affecting multiple parts of our body. There's a really important caveat around this, though, and it's right here. It's not clear if this damage is solely caused by the virus itself or if this is part of our body's overacting immune system. Remember, a certain number of individuals, most individuals, have a mild case. Maybe have a little bit of cough, shortness of breath. About 14% of them ultimately end up in the hospital, and after about a week of symptoms, those individuals seem to turn from an upper respiratory to a lower respiratory illness, and it takes a serious turn for the worse. We aren't 100% certain how much of that is the virus and how much of that is actually an over-response from the immune system. All right, additional data. We talked early on about risk factors, what seems to put someone at a higher risk of having a severe case of COVID-19. Age, that still seems to be an important risk factor. Older individuals are at a higher risk. We talked about chronic illnesses and a suppressed immune system, and I gave you a whole list of potential things. We've now got more data, specifically data from New York City. So a paper that came out looking at 5,700 hospitalized patients with COVID in New York City. So again, this is a subset of the population. We're looking at those that have COVID-19 and had to be hospitalized. 94% of those individuals had at least one chronic health issue, and 88% of them had two or more. So this really lends weight to the idea that these chronic health conditions, specifically the most common were hypertension, obesity, and diabetes, put you at a higher risk of having severe symptoms if you are infected with the virus that causes COVID-19. Suppressed immune system still seems to be one. We're still seeing evidence that males are affected at a disproportionate rate compared to females. There's a lot of data digging into that, understanding why. And we see really across the country that African Americans are infected and have serious side effects with COVID-19 at a higher rate than their Caucasian counterparts. And the data aren't 100% clear. Every state doesn't collect the same information on racial breakdown. But it's thought that a significant amount of this is driven by historical inequities in issues like job opportunities. African Americans often aren't able to work from home. They're in frontline jobs, or they're in housing systems where there's a higher density. They're more likely to come in contact with individuals. They have less access to healthier food and less access to health care. So this is a significant issue that as a nation we have to figure out how to tackle and how to address, but it's driven by long-seated inequities. Okay, now let's move on to what we know from new data about testing and different types of testing. So this happens to be a board that I had left here during the month when we were staying home. And this is the board that we used when we were talking about different types of testing and how testing is performed. So fortunately, because I hadn't erased it, we can actually link back to it. So remember, two key types of testing. Molecular testing, I am looking for the presence of active infection. I'm looking for the genetic material associated with the virus. And serological testing, this is antibody testing. We've explored each of these in previous episodes of Shareable Science Beyond the Blog, so I'm not going to go into detail on them. But I want to say we are now routinely testing between 200,000 and 300,000 Americans on a daily basis. That is a significant increase from where we were even a few weeks ago. The challenge is many experts believe that in order for us to identify regions that are hotspots and to catch them before they begin to expand into epidemic, we need to be testing twice this many individuals. So we still have to crank out more tests, and we have to put them into people's hands faster. Saliva-based testing is beginning to come online. It looks like it is as sensitive as having that long nasal swab stuck down your nose. That's a good thing. That'll make testing easier. And then the big issue, you hear a lot about this, is serological testing. The benefit of this is if it's done well and it's accurate, it can actually tell us who has already been infected. And it can give us a sense of, ideally, who has immunity because they're producing antibodies. The big challenge is this piece right down here. These are less sensitive than we would like them to be. There are a number of high false positives, and that's a challenge. Somebody who truly does not have immunity, but the test says that they actually do, and these are also still in development. So this is not ready for the immunity passport that we hear so much about. And lots of people are going out and having these serological tests, and this is not something that we are at a point where you should be making decisions about your actions based on those results. Okay, that's a whirlwind of content covering lots of different pieces, but there's been a lot of science over the last couple weeks. From this point on, we'll continue to update. Here are the new findings, here's what they mean, and here's how we integrate this in. If you find that this is science worth sharing, please do so. Please pass along to your friends and family. Thank you for watching. I look forward to seeing you next time. Stay safe.